Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I'm Sam Mazer, and I'm joined tonight by our producers, Hartley Lidsky and Avram Rago. Say hi, Hartley and Avram.
Hey, how's it going?
Hello.
It's a big hi. I like it. So our guest tonight is Dr. Angela Weyand, and she's here to discuss hemophilia. But first, let's remind you about the show.
We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Angela Weyand. This is actually her third Cribsiders episode. She is a pediatric hematologist and the Shematologist on Blue Sky. She's also a mother of two and a confection connoisseur. She's an associate professor at the University of Michigan in Ann Arbor, where she focuses on disorders of hemostasis and thrombosis, especially as these pertain to women's health. Tonight, she teaches us about all things factor, how to diagnose hemophilia, and just how impressive 7-year-old children can be.
She really kept the conversation flowing.
Hey, there you go. I like it. So just lastly, Dr. Weyand has been a consultant for Takeda, Bayer, Genentech, and Sanofi. The content provided is for educational purposes only and does not endorse any specific products or companies. All references to medications or treatment use generic names to maintain objectivity and avoid commercial bias. Let's get to it. Hi, Dr. Weyand. Thank you so much for coming on the show. First, because we're more of an informal group, I'd like to ask if it's okay to call you by your first name.
Absolutely.
Awesome. And so, Angela, you're a returning guest, a three-peater, if you will. We just want to start with a couple rapid-fire questions to get you know a little bit better. But as a returning guest, would you mind refreshing our listeners a little bit about yourself? Generally, we like a one-line or something that you do outside of medicine as well.
Yeah, so I'm a pediatric hematologist at the University of Michigan in Ann Arbor. And I love to read and eat lots of different sugar-containing foods of all sorts.
Amazing. I think that will reverberate well with every single one of our listeners.
Any recent sugary treats that came out lately? Anything new?
I'm actually currently addicted to Nerds clusters. I don't recommend you try them if you have not, because it's really actually quite problematic.
They're my night shift snack.
Yeah, they're big now.
I will say I have not tried them yet, but this is the second podcast recommendation with which I have heard nerd clusters being the top.
No, don't do it.
Of all time.
It's a problem. It's like a very big problem. So don't. It's like a gateway. Don't enter.
Yeah, I consider me warned. EZ Resus is your ultimate support to take care of your sickest patients during resuscitation. Whether you are taking care of a newborn during a precipitous delivery, a septic child requiring endotracheal intubation, or a seizing teenager, this offline app has drug dosing, equipment size calculation, treatment algorithms, all available in under 3 clicks. This gives you rapid access to life-saving critical info in a user-friendly interface, taking care of the logistics of resuscitation so you can take care of what really matters, your patient. For those who do not work with critically ill patients, the app also has calculated doses of the most used PO and IV medications, including antibiotics and analgesia. Also, you can find critical first steps for basic and advanced life support, which could be useful for anyone, anywhere. Finally, for those in our audience who also work with adult patients, there is a complete adult section with the same features as in pediatrics, including weight-adjusted dosing for heavier patients, treatment algorithms, and more. So someday you'll need to act outside of your comfort zone, and with EZ Resus, you will be ready. So Cribsiders listeners, here are the benefits. They're made for all clinicians and all patients with a user-friendly interface, 100% offline content and available on any device, drug dosing, treatment algorithms, and equipment size dynamically calculated based on patient characteristics, multiple alerts and content adjusted to age and weight to ensure safety, content entered and reviewed by over 30 healthcare professionals, and available for institutional access, including an online version, group pricing, customizable content, and exclusive features. So, listeners of the Cribsiders get access to a 2-month free trial, letting them use 100% of the features of the app. So download EZ Resus on the App Store or Google Play Store, create your account, Use code Cribsiders, that's code Cribsiders, and then start using Easy Recess. And for more information, visit www.easyresus.com/Cribsiders. That's www.easyresus.com/Cribsiders. And lastly, for learners, that's students and residents, the app is completely free for the first 2 years. Because you've been on the show already, we've kind of asked you these questions before. We have a huge topic tonight. We might just get into it. Is that okay with you guys?
Yeah, sure.
Awesome. Hartley, go ahead. Read us our first case, please.
Amazing. So today we are meeting Jose. Jose is a 4-year-old assigned male at birth patient who's arrived for his well child visit at Cashlek Children's Pediatric Clinic. He was diagnosed with hemophilia A when he was 9 months old after he developed leg pain from a minor tumble while cruising and was found to have a hemarthrosis. He was born after an uncomplicated pregnancy. No other members of his family are known to have hemophilia. Outpatient, he is on prophylactic factor VIII infusion 3 times weekly, administered at home by his parents via peripheral venipuncture. But despite prophylaxis, he typically has episodes of hemarthrosis or hematomas that require an ED visit or a hospitalization every 4 to 6 months or so. Otherwise, he's healthy, he's up to date on vaccines, and he's meeting all of his developmental milestones. So let's just start with the basics. What is hemophilia?
Yeah, so I think generally when people are talking about hemophilia, they're generally thinking about hemophilia A and hemophilia B. There is also hemophilia C, but that's usually not like within the conversation. So hemophilia A and hemophilia B are deficiencies in factors 8 and 9 respectively. They are bleeding disorders of varying severity, right? Patients can be severely affected versus more moderate or mildly affected, but they generally present similar to what you described, with joint bleeding is kind of the most commonly seen manifestation, but also can have things like intramuscular bleeding, and then more catastrophically things like intracranial bleeding.
How do you talk about this condition with parents when you're first explaining the diagnosis?
Yeah, so I think it's an interesting conversation for a number of reasons. I think some of our families that we're meeting have a lot of history and actually probably know more on like a day-to-day basis about hemophilia than I do, right? Because they have multiple family members. They are very entrenched within the hemophilia community, which is a very tight-knit community, and have dealt with hemophilia for generations within their family versus a new family where, maybe they've heard of hemophilia in a very abstract sense. And for those patients, I usually talk about it as a deficiency. And mostly I think about these conversations in terms of severe hemophilia, which is when we're diagnosing them usually as infants, similar to this case, where we talk about missing, a clotting protein that helps our blood to clot and helps our blood to stop bleeding when we have injury to a vessel, and talk about it similarly of, what kind of bleeding we see with that, but that it is in severe cases, a high enough bleeding risk that we do recommend prophylaxis, which is really, I think, the biggest part of that conversation and the one that is the biggest deal to the families, right? Because when you're talking about prophylaxis, historically that has meant intravenous infusions in very small children, which is incredibly difficult and a lot, especially for families that don't necessarily have a lot of interaction with the medical community.
And for my learning, it truly is intravenous. It's not a sub-Q injection. They're getting insects.
So our factor products are all intravenous, and so they have to get intravenous access. And in the beginning, that's the parents doing that, and then as kids get older, they do that themselves. We now are starting to have medications that are not intravenous, but historically and currently, all factor products are intravenous.
And we'll get into the medicines, especially from a prophylactic standpoint. We're going to ask you all about those. But as you're explaining them to, this condition to these families, and you say, hey, you're missing one of the pieces of a clotting system. We were hoping that you could tell us a little bit more about the physiology, more from the medical side. Not to do the entire clotting cascade at all, but just kind of walk us through with what's missing and why is this causing a disease process.
Yeah, so whenever I'm thinking about bleeding, I kind of think about it in terms of like primary hemostasis and secondary hemostasis. Secondary hemostasis being that coagulation cascade that everyone hates learning in medical school, except for me, who loves learning coagulation cascade. And I think, it's important to think about those things because they present very differently, right? You have primary hemostatic defects that present more with mucosal bleeding versus this is a secondary hemostatic defect. The way we're taught the clotting cascade in medical school isn't exactly how it works. So more physiologically how it actually works. We know it's more the tissue factor VII pathway that initiates the whole system and then generates pretty small amounts of thrombin that then is able to activate other factors. So factor 11 at the top of that other side that we think about if you're thinking about the Y of the coagulation cascade or the intrinsic part of the pathway. So it activates factor 11 as well as factor 5 and factor 8. And then that pathway kind of comes into it and is able to generate much larger amounts of thrombin, which is what's so important for forming a clot. So we don't necessarily get into all of that, obviously, with families, but it's definitely how we kind of think about coagulation now more than just the two. When you look at the two pathways and learn them, it's kind of seems like they're happening at the same time and converging. And
so when you talk about hemophilia A, we think of that as a factor 8 deficiency, and hemophilia B, we factor 9 deficiency. How are you getting subsets of that deficiency? It sounds like you can have a very severe where you have absolutely zero, and you have a mild where you have some. How does that kind of work?
Yeah, so, a lot of it is based on the specific genetic mutation. And we also know that there's kind of the amount of factor you make, but that also there are patients who have certain levels of factor 8 or factor 9, but have abnormal quality of that factor 8 or factor 9, that it's not working very well. But we know this, I think, is actually super important to me as someone who focuses on a lot of women's health and bleeding, because I think within hemophilia, it's very much thought of as a male disease, but actually females can be affected and are more commonly affected than people realize, and are often those patients who have higher levels of factor 8 and factor 9, but can still have significant bleeding.
Yeah, that was kind of my question. I was typing in the background about it. I think that's what we're always taught, being X-linked recessive. Do you see females with severe disease, or is it still more mild, or still the same kind of spectrum?
Yeah, so there are females with severe disease, right? And so some of those are things that you probably learn in medical school, right? If you have Turner syndrome, then you only have one X. Or if you're severely lionized, right? All of our cells have X inactivation. And if the majority of your cells, the normal X is inactivated, then you're going to have only that abnormal X expressed. So there are kind of the more severe cases like that. Or there's also cases of you have a father who carries an abnormal gene and you have a mother who carries an abnormal gene. So you have compound heterozygosity. And then there's a lot more of the women affected by hemophilia, or at least female assigned at birth patients, are in more of the moderate to mild range. And the vast majority of them we're not actually identifying. So if you think about epidemiologically, how many possible assigned female at birth relatives for every male, then look at how many of them are likely to be carriers and how many of them, looking at a bell curve of what their factor level should be, about 1 out of 3 patients in all hemophilia registries should be assigned female at birth, and the numbers are nowhere near that. So I think as a medical community, we're taught this is not something that affects females. I speak every year at a meeting that's specifically for women affected, and I'll hear stories of these women who will go to the ER and say, I'm having a joint bleed, I have hemophilia, and the doctors say, oh, you must be confused. Women don't have hemophilia. So I think it's a huge problem that these patients, one, aren't even identified. And then I think as a medical community, because we've been taught something so far from that, a lot of times they're dismissed and not cared for appropriately.
Yeah, I'm so glad that you brought that up, because I think that's, not something that we learn in med school, and absolutely contributes to health disparities in this field. And I really appreciate that you have so much expertise in that particular area. So thinking about how we are diagnosing people with hemophilia, what does that look like? How and when are we typically identifying these kids?
Yeah, so patients with severe hemophilia are obviously, as you would expect, diagnosed earlier than patients with mild or moderate. We have patients with mild disease. I have, adult colleagues who have diagnosed patients in their 70s for the first time with mild hemophilia, versus severe patients are usually diagnosed within the first year of life. Sometimes that's after a circumcision where they had prolonged bleeding. Sometimes it's prolonged oozing after heel sticks, like for newborn screening. Sometimes we know that the mom is a carrier, and we sometimes know that the baby is affected before they're born. And if not, usually, recommend testing shortly after birth. But it kind of depends when they're presenting. So if they're not circumcised, or we don't know at birth that they could be affected, then they may present like this case a little bit later and have the testing done when they're first exhibiting that bleeding symptom. But ideally, especially in our severe patients, we would know that the mom may be delivering an affected fetus, and then would recommend testing right after birth, and typically would recommend cord blood testing, as these patients obviously are at risk for having severe bleeding. And there are case reports of patients who, are in the NICU and they couldn't get cord blood testing, so they get an ART stick and then get huge, bleeding complications from that. So it's optimal if we can get a cord blood lab level, but that's not always possible, unfortunately.
Yeah, and along those lines, it sounds like we should be thinking about hemophilia if we have bleeding, because it's a bleeding disorder. Like, what would you say is the bleeding type presentation where I should be like, you know what, I should start thinking about hematology right now?
Yeah, so I think that it's interesting because there are patients that we've seen in clinic that end up having severe hemophilia, and maybe they had some prolonged oozing with heel sticks, which is hard to really define, right? What is a normal oozing with heel sticks? But what you'll find is that the nurses in the newborn nursery or the nurses in the NICU do a lot of heel sticks, right? And if they're saying this is more than it should be, that's always something to listen to, because they do, you know what I mean? I think as a physician who's never even done a heel stick on an infant, I don't know how long it's supposed to bleed, but if I have a NICU nurse who's been there for 25 years and she's like, this is not right, then I'm definitely listening to her. But I think it is different for every patient, because what I was starting to say and went off on that tangent was that we've had patients who've had major surgery and kind of done okay, and then had prolonged oozing from their heel stick afterwards and were tested and found to have severe hemophilia. And so it's hard to say because everybody presents a little bit differently. And you'd like to think if someone had major surgery and didn't have bleeding that they don't have a significant bleeding disorder, but that's always challenging because surgical hemostasis is so important. And if you cauterize every single vessel that could possibly bleed, most people, even if they have a bleeding disorder, can do okay.
And I like to think that there's an easy answer for that, but it's okay that it's not. It's just like, hey, if you're thinking that or someone's letting you know that there's a little bit more bleeding than expected, then you should put that in the back of your brain, is what it sounds like.
Yeah, absolutely.
I have a small technical question. I'm hearing you say moderate, mild, moderate, and severe. Are those technically defined terms, or is that
they are?
Okay. Would you be willing to go through that?
Yeah, so severe hemophilia for A and B is defined as factor levels less than 1%. Moderate is 1 to 5%, and then mild is above 5%, all the way to, depending on who you talk to, 40 or 50%. So internationally, hemophilia is defined as factor levels less than 40%, but most people I know in the United States use less than 50%.
Okay. And do we find that clinical bleeding correlates with those categories as well?
So that's how they're defined, but interestingly, if you look at the studies that kind of looked at the bleeding and then made those cutoffs, there weren't all that many patients, and there were patients that didn't necessarily fit within that. So I think like anything, it's kind of a good way to help us estimate how much bleeding a patient's going to have, but there are other things that contribute to that. And so, it's standard of care for a patient with severe hemophilia to be on prophylaxis, but there are a lot of moderate patients who bleed like patients with severe hemophilia, and they also need prophylaxis. And then there's also even some mild patients that are within that same category.
And so as we're doing our workup piece, and we're going to get to kind of the tests and stuff like that we'd send in a second, I'm thinking, I see a patient with bleeding. We just talked about not really being able to quantify exactly what bleeding means as far as a inherited bleeding disorder. Is there something specific that should make me think towards hemophilia versus not? Or should I be like, all right, I see bleeding, I'm thinking bleeding disorder, and now I'm going to start my workup?
Yeah, so I think it's hard. I think when you're taking a board exam, right, there's certain types of bleeding, right? Like you see umbilical cord bleeding, that's factor 13 deficiency, right? Or you see epistaxis and heavy menstrual bleeding, that's von Willebrand's disease, right? But an infant with von Willebrand's disease is not going to have epistaxis and heavy menstrual bleeding. And there are patients with hemophilia that have really bad epistaxis. So we like to kind of say like, okay, they kind of fit within these categories, and then you meet the patient and they didn't read the textbook. And so it's not necessarily as clear, but I think definitely joint bleeding is something that is pretty specific to hemophilia. It doesn't necessarily happen at all as close to the frequency in other bleeding disorders. So that's definitely something like this infant where, you have blood in your joint. The first 10 things on your list are hemophilia A, hemophilia B alternating with each other, right? Like that's what that's going to be.
Yeah, great. So we talked a bit about when we should suspect hemophilia. What labs do you want us getting? When are we going to be calling you all? What's the workup look like for either someone in the emergency setting or the outpatient setting?
Yeah, so I think we can start with more broad clot-based assays, so PT and PTT. PT is obviously not helpful in hemophilia because that's looking at extrinsic, so it's just going to capture factor 7, but for hemophilia A and B, usually PTT is prolonged. It's a very imperfect test though, and so you definitely need factor levels. And so in that case, you'd send, factor 8 and factor 9. Historically, that's been a clot-based assay. Now we have chromogenic methods, and within hematology, we like to send both of those, and they're more helpful in some patients than others, and is a little bit outside of probably the scope of this discussion. But it is important to recognize with your clot-based assays that a lot of your results, it's difficult to know this, but it is helpful to know what assays you're using and how sensitive they are. So in pediatrics, right, if we get a PTT and a kid who's going to get a tonsillectomy, which is not something that we suggest you do, but say that we are screening every kid who's getting a tonsillectomy with a PTT. The most common cause of a prolonged PTT in your average kid on the street who's not presenting with bleeding symptoms is a transient lupus anticoagulant, which we don't care about. So if you're running a coagulation lab, when you're deciding which reagents and how sensitive you want your test to be, you're balancing these things of like, we want to be sure we pick up factor deficiencies that matter, but we don't want to pick up every single lupus anticoagulant that doesn't matter at all. And so what that ends up leading to is in labs such as at the University of Michigan, our lab, you can have a normal PTT and have mild hemophilia. So a normal PTT does not necessarily rule out mild hemophilia. And the other challenging thing with that is that if you think about it, right, your PTT encompasses a lot of factor levels, right? So it's all of your intrinsic factor levels, so 12, 11, 9, 8, and then you have your common pathway factor levels, right? 10, 5, 2, 1. And I think that we don't necessarily think about that. And so, for example, you could have a patient who had severe factor 9 deficiency, but who was in a super, super inflamed state where we know factor 8 can go really, really high. And so you could presume, like, say you had a patient and you said, oh, they have a history of factor 9 in their family, we need to take them to OR emergently, just get a PTT. Well, that PTT, if they're in a state where they have a ton of inflammation going on and their factor 8 is high enough, that their PTT could be normal, even though they have severe or moderate factor 9 deficiency.
So in a situation like in DIC where you have like consumption of factors, I guess those aren't preferentially consumed one or another. Are there other cases like that? Are we ordering factor levels? Are we ordering more advanced studies? At that point, are we talking with y'all as consultants?
Yeah, so exactly. So in DIC, they're not consumed preferentially, but they do have different half-lives and they do have kind of different physiology. And so if it is a patient where the PTT and the PT is prolonged and you're thinking about DIC, I oftentimes will send factor levels just because it's difficult to differentiate DIC from liver failure.
If you've ever listened to a heart murmur and thought, did I really hear that? You're not alone. I've had moments on the wards where I thought I caught something subtle, maybe a faint gallop or irregular rhythm, but with background noise, a restless patient, and no time for a second opinion, I had to move on. That's where Echo Health came in to help me. Being able to record the sound meant I could revisit it later, and with the help of Echo's AI, I got confirmation that what I heard wasn't just in my head. It's like having a second set of expert ears, even after we've left the room. Echo combines the stethoscope you already know with enhanced audio and advanced AI to help you detect heart and lung conditions earlier and with more confidence. Hear with precision even in noisy environments. Echo's digital stethoscope amplifies heart and lung sounds up to 40 times, and noise cancellation cuts out distractions. And detect disease earlier. Unlock murmur and AFib detection powered by Echo AI, along with sound recording, sharing, and more for earlier diagnoses and seamless collaboration. And improved diagnostic accuracy. Backed by 4 million heart sounds and 8 FDA clearances for devices and AI algorithms, those with Echo are 2 times more likely to detect heart disease. And lastly, a personal benefit, teaching. I've used Echo recordings to walk learners through abnormal heart and lung sounds and even to help patients better understand what's going on with their own bodies. It turns the stethoscope from a black box into a real-time teaching tool, which is pretty amazing. So we trust Echo so much that we worked with their team to create a special offer just for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/Cribsiders. Your purchase is HSA and FSA eligible and may qualify for CME reimbursement. Plus, Echo guarantees you'll detect heart and lung conditions more confidently. If you don't, return it for a full refund. Go to echohealth.com/Cribsiders for $50 off plus a free chest piece cover. That's EKO health.com/Cribsiders. Get $50 off plus a free custom chest piece cover at a $25 value when you go to echohealth.com/Cribsiders. So we just said, PT and PTT, not the most sensitive and versus specific, because the lab's trying to figure it out the same way we always balance sensitivity and specificity. You're like, hey, if we're thinking hemophilia, we should send in factor 8 and we should send factor 9. We just kind of talked about before that we're not like 100% sure this is hemophilia or not based on bleeding. We just know it's bleeding. Are there other factor levels that you recommend us sending, kind of when you're doing this workup? Obviously, when we're talking about a hemophilia podcast here, ultimately 8 and 9 are going to be low. But I'm just curious, like when you do that generic testing, you're not just sending 8 and 9?
Yeah, so if I'm seeing a patient just with bleeding in general, right, and I have no idea what they could possibly have, then I'm sending like those screening tests. The PT is actually pretty sensitive for like factor 7 deficiency, so I'm not typically sending that up front. But knowing that you can miss a mild deficiency of 9 or 11, I'm usually sending those. You can also miss a mild deficiency of factor 8, but I also am usually sending a von Willebrand's panel that would have your factor 8 on there. And then you also have to think about things like factor 13 deficiency that isn't going to have abnormal PT or PTT, as well as like fibrinogen disorders where you might want more specific testing like a thrombin time.
And do you actually look for liver stuff too during that time, as well? Or you're like, hey, I know that this is a young infant and this is likely an inherited disorder, and so therefore I'm skipping that issue?
It kind of depends on the infant, right? So if you have a baby who's sick in the NICU going through a sepsis rule out and then I'm thinking like, okay, maybe more DIC versus like this is a healthy newborn that just happens to have, a little bit of oozing from their heel stick, but otherwise is quite well. But it's also a little more challenging in newborns, right? Because developmental hemostasis is very different than you and I's hemostasis, right? And so that can be challenging in terms of diagnosing hemophilia specifically. So most of our coagulation factors are low at birth. So factor 9 in any infant is going to register as low on your reference interval. And so it can be difficult to differentiate, is this really factor 9 deficiency versus normal newborn hemostasis? So typically we would recheck labs around 6 months of age to evaluate that. And then with factor 8, that can actually be elevated at birth. If a patient has severe hemophilia A, then you're probably going to pick that up. But if a patient has mild hemophilia A, that could be missed if you just check right after birth because of the elevation from being an acute phase reactant and also just developmental hemostasis.
So there's a lot of nuances here is what's pulled out. And that's why we have our neighborhood hematologist to ask. But it sounds like if we're, going off the bat, look, PTT, factor 8 and 9, von Willebrand panel. And
don't forget 11.
In 11. Sorry, thank you.
Von Willebrand panel and 13.
And then with that in mind, let's say factor 8 comes back low, like we're talking about here. What other tests are we doing on top of that now that we're kind of suspicious for hemophilia?
Yeah, so, a low factor 8 level, depending on, a low factor 8 level is consistent with hemophilia A. And so then we're just kind of thinking about where within the severity spectrum that lies. There really aren't like other things that would cause just isolated low factor 8 or factor 9. So typically that is enough for your diagnosis. Sometimes we will do genetic testing, and that can provide more information about the specific genetic mutation. Sometimes that's helpful in terms of determining risk for inhibitors, and that's kind of the biggest reason why we would do genetic testing.
So say we have a child that might have been missed. They're this, younger toddler, and we're ordering labs. We're suspicious for hemophilia. As we're sending off to hematology, what should we do as far as counseling? Are we limiting activity off the bat, procedures, just given our clinical suspicion? And then what's the urgency of that consult? Is that something you're seeing like ideally like that week, or is it, a little bit less like urgent?
Yeah, so it kind of depends on the context. So I would say if you had a normal newborn that's born and is having prolonged oozing from a heel stick, and you send a PTT and it's prolonged and your factor 8 level is low, that's something that would be more urgent or emergent where I would talk to hematology right away, especially if that family was interested in circumcision. But also in patients with severe hemophilia, typically we would do a screening cranial ultrasound to make sure that there's no intracranial hemorrhage from birth. So that would be a more, urgent, emergent. Same with like the patient in this case, where if they have bleeding in their joint, that's a really big deal and really needs to be treated appropriately right away. I'd say if you had a patient who, is 2 months old and has a little bit of bleeding and had a low factor VIII level and there's no procedures or anything, it's a little less emergent than those other two situations, but kind of depends on if there's any upcoming procedures, how severe the factor level.
Call your friendly neighborhood hematologist.
Yeah. We
And I
are
think
always
that-
happy to talk if you're unsure.
And that's like, are you going to the emergency room right now versus like, as we're the primary care doctor, we're like sending you to the emergency room and obviously you're going to get a hematologist sees them that day in that moment versus if we think, hey, doesn't need an emergency where, it sounds like you can see him at that time. So, we can hopefully have that gestalt as well, kind of when we see our patients that way.
Incredible. Okay, so we've talked to our friendly neighborhood hematologist. We've diagnosed someone with hemophilia. Obviously, as generalists, we wouldn't be prescribing anything for prophylaxis, but would love to understand your process as you think about prophylaxis. It sounds like the mild, moderate, severe classification and bleeding phenotype are involved in this decision, but would love if you can talk us through who needs to be on prophylaxis and how you decide which one to use.
Yeah, so historically, we've had factor products for both factor VIII and factor IX deficiency or hemophilia A and B. Typically, the recommendation, kind of international guideline recommendations, has been that patients with severe hemophilia A or B should be on prophylaxis. And that is typically, historically, that would occur around or a little bit before their first birthday, around the time where they're getting to be more mobile and we want to prevent hemarthrosis. We know that bleeding into a joint one time puts that joint at risk for further joint bleeding, and that's where a lot of the morbidity with hemophilia comes from, is having current bleeding into your joint that then can cause longer term problems, including with mobility and things like that. So any patient with severe, and then patients who are moderate or mild, it would be more determined based on their bleeding phenotype. So definitely any patient who's having spontaneous hemarthrosis or spontaneous bleeding would get put on prophylaxis. But patient who's having hemarthrosis even from just like activity, not necessarily like one discrete traumatic episode, but in just the course of their normal activity, we would also put those patients on prophylaxis. Historically, the international guidelines were to keep factor levels above 1%. And there's some nice studies that show like kind of that just having 1%, your rate of joint bleeding is a lot lower than having less than 1%. But as time has gone by and we have better products and we've learned more, it's clear that we need probably higher trough levels than that 1%. It has been difficult with both hemophilia A and B because the medications are intravenous, and that's part of why we typically didn't start prophylaxis until closer to their first birthday. Patients who, for example, if you had an infant who was born with an intracranial hemorrhage, that patient would get started prophylaxis a lot earlier, but that would typically require a port to be placed with the risks associated with that, right? So thrombosis, infection primarily. So typically we would wait till they're a little bit bigger and aren't necessarily starting them on optimal prophylaxis, but kind of trying to enter the shallow end in terms of teaching the parents how to infuse, having them probably come once a week into clinic so that parents can learn how to infuse them, and then kind of going from there. But it's really challenging, as you can imagine, because they're little, and it's hard for even our experienced phlebotomists or nurses to get intravenous access sometimes. So having somebody do it at home that doesn't have any of that training is tough. But for factor VIII, especially, the half-life of factor VIII is between 8 and 12 hours. And so when you talk about this patient, right, 3 times a week of intravenous infusions is a ton. And there's been a lot of work done over decades of trying to extend the half-life of factor VIII that has not been super successful up until more recently. Now we have a factor VIII product. Efanesoctocog alpha is the generic name, and they actually have engineered the factor VIII molecule to not bind the patient's endogenous von Willebrand factor. So some really nice work showed us that that's why all of our trying to extend the half-life didn't work, is because it was cleared with the von Willebrand factor. If you remember that factor VIII binds von Willebrand factor. And so F-inositol alpha was designed so that it doesn't bind it, and it's able to actually be infused once a week instead of multiple times a week. And even with the once a week dosing, the trough levels are much higher than we historically were able to obtain. So that was a big thing. And factor 9, the half-life is longer and doesn't have that issue with von Willebrand's factor. And so the extended half-life factor 9 products have been better than factor 8 for a long time. And some of those people can do weekly. If you get to older ages, even like every 10 days, sometimes every 2 weeks. But in the little ones, the other problem, not only that intravenous infusion is difficult because they're little, but they also clear factor more quickly than adults. So often would require more infusions than an adult would.
Yeah, I just maybe a quick thing. So as far as factor 8 and factor 9 deficiency, you talked about the half-life being different. In general, other than counseling for future purposes, is there any real clinical distinction between the two for you other than that frequency of infusions?
So there's the frequency of infusions. There's definitely differences now in terms of kind of so hemophilia A is much more common than hemophilia B. And as such, there's been a lot more research into treatments for hemophilia A. So there's a lot more kind of pipeline medications being developed for hemophilia A. The half-life is a little different. So the products, even thinking about factor, less frequent infusions. And then there's some kind of more esoteric stuff about kind of the distribution of factor 9, where kind of maybe what we're measuring in patients is not necessarily reflective of all of the factor 9, given its volume of distribution is a little bit different. But those are the biggest things I'd say.
So it sounds like we have factor that actually lasts for a lot longer than we used to before, which is fantastic. Would you mind kind of walking us through the dosing guidelines that you'd recommend depending on each classification of hemophilia?
Yeah, so factor 8 and factor 9 are dosed differently. So for factor 8, we typically think about 1 unit per kilo increasing your factor level by 2%. And so typically if you have a patient with severe hemophilia and you want to get to 100%, then you would do 50 international units per kilo to get there. It is a little bit different just in terms of we oftentimes will do pharmacokinetic studies to see where they're getting to at their interval, looking at troughs to make sure that they're in a good spot. And that can be, as I mentioned, the tinier the child, the more quickly they clear things. And so unfortunately, in the littlest ones, we have to sometimes do more frequently versus factor 9, where 1 unit per kilo increases your factor 9 level by 1%. So for those patients to get to 100, we would do 100 international units per kilo if they were severe. Usually within pediatrics, we don't worry so much about overshooting. With adults, sometimes if you get really high factor 8 levels, especially, that's a risk for thrombosis. But in most of our kids, they don't really have other thrombotic risk factors. And so oftentimes, even if a patient is moderate or severe, we will just give them 50 per kilo because if they're 3%, then they're going to get to, 103% or whatever. So it's not usually that much of a difference based on the severity.
And just out of curiosity, why do we shoot for 100%? Although we talked about before that maybe anything over 50% is fine.
Yeah, so I think it's challenging. There's a lot of talk right now because we have better medications, like I mentioned, about what we should be doing. I think historically within hemophilia care, we kind of did what we were able to do, right? Like we tolerated trough levels of 1% because we aren't really going to ask someone to infuse twice a day, every day, right? Like that's not reasonable. I mean, some people would say 3 times a week is not reasonable, but we knew we needed to keep patients above 1%. But now that we have better medications, there's a lot of talk of like what is normal and what is good enough. But if you think about someone like you or I and our factor 8 level, if I tested your factor 8 level right now, say you're at 100%, and then I said, okay, now go run a marathon, right? And then I'm gonna check your factor 8 level again. Your factor 8 level is nowhere near 100%, right? It's like way higher. And so we know that the natural response, which is an appropriate response, is to increase your factor 8 level with stress in these, surgery, like all of these different things, right? Increase your factor 8 level. And so that's not happening in a patient with hemophilia. So even if I get them to 100%, if they're going into surgery where we know you or I, our factor level wouldn't be 100%. So we do use 100% just because that makes us feel like that's a good level, but there's a lot of discussion right now about like what actual normal is. And even if you think about the definitions where internationally less than 40% is considered hemophilia, but what about all those patients between 40 and 50? Like they bleed and it's not a normal factor level. So there's a lot still to learn in there, I think.
That's really helpful. Other than factor or these extended half-life factors, are there other prophylactic medications that are currently being used in pediatrics?
Yeah, so there are now non-factor products. So within the last 10 years, one product came out called emicizumab, which was initially approved to be used in patients with inhibitors, but then was subsequently approved to be used in all patients with hemophilia A. It's actually a bispecific antibody that is the bi part of the specific antibody is to factor 9 and factor 10. So it basically brings together factor 9 and 10, which is what factor 8 does. I like to call it a dating service. And, it's very effective, and it's incredibly effective and is really life-changing for our patients with inhibitors who previously didn't have great options for prophylaxis. But because it's a bispecific antibody, or because it's an antibody, it's actually a subcutaneous injection rather than the intravenous. And it has a long half-life. And so it's dosed either once a week, once every 2 weeks, or once every 4 weeks. So that's really been also practice-changing for pediatrics because, as you can imagine, we used to not even start prophylaxis until when they were more mobile, despite the fact that we know there's a real risk of intracranial hemorrhage in those first kind of 6 months of life. And so now the National Bleeding Disorders Foundation has a medical and scientific advisory committee that kind of puts out recommendations. And when that was approved, they put out a statement saying that it should be considered in infants much earlier on to try to avoid the small but very real and possibly devastating risk of intracranial hemorrhage. So that's one that has been approved now for over 5 years. There's a lot kind of in development. There was one recently approved called marstacimab, which is also an antibody, as you can tell from the mAb, but it is actually targeted to TFPI. So a lot of the emicizumab is kind of considered a mimetic because it mimics the factor 8, bringing together 9 and 10. But then there are what we consider balancing therapies. So if you think about coagulation, you have your procoagulant, so factors right here within that coagulation cascade. And then you have your natural anticoagulants, right? So antithrombin, protein C, protein S, and TFPI. And so there is literature from kind of big population-based studies that if you have hemophilia A, but you also have factor 5 Leiden, that like maybe your bleeding phenotype isn't as severe as if you didn't have a clotting disorder, right? And that would make sense if we have decreased levels of procoagulants and then we also decrease the levels of anticoagulants, maybe that would balance each other out. And so these new rebalancing therapies exploit that idea. And so marstacimab is a antibody to anti-TFPI antibody and is also subcutaneous and can be used for prophylaxis and was just recently approved.
Which one is considered first line out of all of those?
So I wouldn't say that there's necessarily a first line. So I think when emicizumab was first approved, that was before efanesoctocog alpha had been approved. And so the options, if we were starting someone with factor 8 deficiency newly on prophylaxis, would be one of we called them extended half-life factors, but they weren't all that extended, and they would have to be dosed at bare minimum twice a week and more likely 3 times a week. And so the option would be 3 times a week intravenous versus subcutaneous once a week, once every 2 weeks, or once every 4 weeks. So especially in young kids, a lot of programs, hemophilia treatment centers, a lot of patients were just started on emicizumab at a young age because that's just so much easier. It is very different though than factor replacement. So if you think about factor replacement, you have high peaks. So we give you the factor and within, an hour or so, we have like a very high peak. So you're going to get to that 100%. And then over time, you're going down like a normal half-life curve, right? And then you get to your trough and then we give you another dose and you go up and then right? So you're very much peaks and troughs. That's not how emicizumab works. So emicizumab provides kind of steady state hemostasis. So you're never getting those high peaks or those low troughs. And they try to estimate like a factor 8 equivalence because we like to use factor 8 because that's what we've used forever, right? You're replacing factor 8. We need to know where we are. And people estimate it's maybe around 15%. So you're basically converting a severe hemophilia patient with severe hemophilia to a patient with mild hemophilia, which means they're not going to have a lot of spontaneous bleeds. And most of the patients do super, super well. But if they have trauma, they're still going to bleed and you're going to need to give them factor. It's a very different treatment paradigm. So currently, I would say there's not necessarily like a first line that patients, at least with hemophilia A, would be started on one of those two options, either a factor product or emicizumab. And marstacimab has really only been approved for the last, I don't know, less than a month, I would say. And so that has not been used as much and is currently only approved for use in non-inhibitor patients and is dosed more frequently than emicizumab. So isn't necessarily providing that same, like, okay, this is very different and beneficial in ways that what we currently have isn't, if that makes sense.
I do have two questions, but the first one, just as we talked a little bit about inhibitor patients, initially when we were talking about testing, we had mentioned genetic testing and kind of left it at there. Is inhibitor testing specifically for inhibitors to factor VIII or something like that, is that a separate test than the genetic testing that you would send?
Yes. So absolutely. So unfortunately, inhibitors to factor VIII and factor IX can occur. As you can imagine, it's more common with severe patients who have no endogenous factor. And so when we infuse factor, their immune systems see that as foreign and can develop antibodies. And that historically has been a huge, huge problem and one of the kind of scariest, worst things that can happen to someone with hemophilia. When emicizumab was approved, that became slightly less bad, but still is not optimal, right? Because you're still going to have those situations, like I mentioned, where they need surgery or they have severe trauma and they need treatment, right? Like this 15% isn't going to be enough if you're bleeding in your head. So you still need something to treat an acute bleed or to give around surgery. But typically, especially with our young patients who are started on factor, we would check inhibitor status regularly as the highest risk for inhibitor development is in the first 20 exposure days. And most of them occur then and almost all of them occur before 50 exposure days. And so definitely in those early times. The issue is now that we're using emicizumab so frequently in little ones is that it used to be you started prophylaxis a little bit before a year. You were doing maybe 3 times a week factor. So you got to 50 exposure days quite quickly, right? Like that doesn't take all that long. Now with emicizumab, patients aren't necessarily requiring factor. And so it's completely changed kind of the time frame and how all of that looks for in terms of when patients are going to develop inhibitors that we don't really know anymore, right? Because developing, having your first exposures to factor VIII all within the first 2 years of life is a different immune milieu than having your 20th exposure day when you're 20 years old or even older than that. So it's definitely going to change how that looks. And we don't necessarily understand how different that's going to be yet.
Awesome. And my final question before we move on to the next piece, and you can say, no, it's way too more complicated than this. But if I asked you straight up as just expert opinion, which would you rather start as your first line? Would you rather start long-acting factor or would you rather start emicizumab? Just as a like this is what I usually do first, or is it more complicated than that?
So I think it's a little more complicated than that.
Totally cool to say. Yeah, absolutely. I totally get it. I know there's a lot more, and you literally do years of training to figure this stuff out. And I'm asking right now, I was just curious if I should be thinking, hey, this is where we're at right now in medicine, and this is what we should be doing and what I should be seeing. But if it's more complicated than that, we will just leave it alone and say, go to hematology fellowship or refer to a hematologist and go from there.
Yeah, it's always, hey, I have a quick question for a fellow or for a consultant.
Yeah.
Exactly. I have a curbside, and you're like,
a curbside.
Yeah, that's a 3-year fellowship, actually. Thank you very much.
Yeah.
Whether this is your first episode or you've been with us since day one, you know our goal has always been to share clinical pearls and practice-changing knowledge in pediatric medicine. So let's talk about something that actually changed my day-to-day as a hospitalist, FIGS. I can't walk into a clinic or hospital without seeing people in FIGS scrubs. And I get it. I wear them too. They're incredibly soft, form-fitting, and durable. And it's not just us. If you've been watching a certain popular emergency room drama on TV that may or may not take place in Pittsburgh, Pennsylvania, yep, they're in FIGS too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids, and kids come with messes, I love that FIGS are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine over 50 times and they still look brand new. All of that and so much more is why we've teamed up with FIGS. Now Cribsiders listeners can get 15% off. Just go to wearfigs.com and use code FIGSRX. That's wearfigs.com and use code FIGSRX to get 15% off. All right, Hartley, go ahead. Take away our next question.
Yeah, so I'm curious, just from the length of these generic names alone, I can tell that these medications are expensive. We always try to talk about sort of non-medical determinants of health and how that affects care. Can you talk about medication access for patients with hemophilia?
Yeah, so they are very, very expensive, and they are some of the most expensive medications that are prescribed in the United States. And severe hemophilia, both A and B, are rare disorders, and so there aren't a lot of patients affected. But as far as like the cost per patient, it is incredibly high. I think there are a lot of programs in place in the United States that make it so that, you know, I work at a large academic medical center. We have patients that have private insurance and Medicaid, you know, all different types, and even like uninsured patients, obviously. And they all are able to get these medications that are incredibly expensive in some way, right? Either the companies have programs if they are uninsured, or we are able to get them covered by Children's Special Health, which is the kind of Michigan children's insurance program. The issue really is more of an international inequity situation, where we know that about 70% of patients in the world don't have access to treatment. And that's not just a huge part of that is not being on prophylaxis, right? And so we have patients who are adopted into the United States when they're 15, and they've lived in countries where prophylaxis is not available, and they come and their joints look like patients, you know, from 40 years ago, where they have huge target joints that are very, very abnormal, and despite really optimal prophylaxis will continue to have morbidity around those joints because they've just had so many bleeds, and unfortunately that does damage that isn't necessarily reversible. So it's a huge health equity issue, and there's organizations, one specifically, the World Federation of Hemophilia, works with a lot of the pharmaceutical companies and provides a lot of factor kind of worldwide for free, but it's increasing in volume, which is good, but still there are a lot of patients that don't have access to appropriate care.
Cool. I imagine a lot of these kids might need procedures such as, you know, going to the dentists or surgeries. How do you prepare for them for that? Do you make changes related to their medications or manage other management decisions?
Yeah, so it kind of depends on the patient and the procedure and what prophy they're on. So, for example, if you had a severe hemophilia patient historically who was on factor or currently is on factor, depending on the procedure, we would typically, you know, recommend they do their regular factor prophylaxis just before the procedure, kind of in the 30 to 60 minutes before the procedure. And then depending on the procedure, would keep their trough levels higher, so more frequent factor dosing in the days after the procedure, depending on how major the surgery was and what their kind of overall bleeding risk for that procedure is. With imicizumab, that has, as I mentioned, kind of changed a lot of patients with severe hemophilia into patients with mild hemophilia. And so it's been interesting to see how procedurally that works, because I've spoken at international conferences where they'll be talking about dental procedures, and half the people there are like, we don't give anything additional for dental procedures in patients on imicizumab, and the other half are like, oh my gosh, we can't believe you would never not give factor. Like, we give factor to everybody who's on imicizumab. And so I think that's something where people have different practices, and we're continuing to learn, you know, what people need. But it's also challenging because I think I mentioned before, like, surgical hemostasis to me is one of those things that, like, as a hematologist, we have no control over, but actually has a lot of impact on whether people bleed. And that's why you can go to a conference and talk to somebody who's like, I had a patient on imicizumab that got their wisdom teeth pulled. They didn't need anything. They did fine. And someone else is like, well, I had a patient where that was not the case, right? But you know, were the wisdom teeth impacted? How did they, you know, what was the approach? Was all of these different things kind of play into that. So it's difficult to know. And that's why it's also difficult for there to be like standardization of how things are done.
And right now, are you recommending people on imicizumab also just getting a dose of factor right before, or is that not the recommendation at this time?
Yeah, generally, we oftentimes will do that for most procedures. And I think part of what I mentioned before in terms of like access to products and those sorts of things also probably plays into that.
Yeah, I can imagine. All right, we've done a lot of planning and things that we know. Hartley, would you mind taking us more to our emergency setting?
Absolutely. So you are now working in the pediatric emergency room at Cashlek Children's, and Jose comes in. He was at recess and he took a tumble off the monkey bars and developed some leg pain. His vitals are stable, but his right knee is scraped, and he has an edematous and painful knee joint. He can't really flex his knee more than 20 degrees. So we talked about what we try to accomplish outpatient, but in situations when we can't expect, how do you change medication dosing when kids are admitted with an acute bleed?
Yeah, so I think it's interesting because a lot of our treatment for hemophilia is outpatient. Like I don't know if you guys have done much like inpatient pediatrics, but on our inpatient hematology service, it is a rare thing for a hemophilia patient to be admitted. And part of that is that historically, a lot of their patients who are admitted were patients with inhibitors, and now with imicizumab, they are doing a lot better than they were before. So even with patients without inhibitors, for the most part, a lot of our even joint bleeds are able to be managed outpatient. And so a lot of times, especially in patients that are very adept at home infusions, that are familiar with what a bleed feels like or presents like, they may call us and say, I think I'm having a bleed. They call us. Some of them don't call us, right? They say like, oh, I'm having a bleed, I'm going to treat this at home, and if it doesn't get better, I will call. Versus there are patients, they've never had a bleed before and they're not even sure. They're more likely to come in, but kind of what you're describing is a pretty classic scenario for a joint bleed. And in that case, whether they were on factor or not, we would typically give that like 100% correction of factor and then typically go from there. And that oftentimes, depending on the factor, especially with efanesoctocog alpha, their kind of pivotal phase 3 study that was published in the New England Journal found that most, I think greater than 96 or 97% of bleeds in those patients resolved with one infusion of factor. So a lot of times patients would just need, that one infusion. So even if they did come to the emergency room, if they were able to get a product like that, they wouldn't necessarily need to be admitted versus previously if it was something that was shorter acting, especially if they didn't feel super confident doing home infusions, those patients may have needed to be admitted.
And are there any specific indications you would say to just give factor right away? I know it's a different world now.
I'm a big proponent of like giving factor no matter, like there's no downside, right? I mean, there are patients where maybe they have a really high inhibitor risk and they're mild or moderate, and like someone could say, well, you're exposing them to factor, maybe they're going to develop an inhibitor. But for the most part, in 99% of the cases, you're just making their factor level normal. You're making them like yourself, right? There's not a downside other than product usage, right? But they're already probably using a lot of product. So definitely it's one of those things, especially with more emergent things like someone hit their head. Like we don't wait for the CT scan to give product, right? They bring the product from home. We don't have them get it from the emergency room because a lot of times it is not necessarily the product we would want. Or it's just like, by the time you order it in the emergency room and they figure out the right dose, you know what I mean? Like we have them bring it the moment that they hit the ER, someone's infusing it, and then they get the CT and then they, do all of that because the quicker you get it in, the quicker it's working and treating that bleed.
And just to kind of expand upon that, bringing from home. So that's kind of the recommendation and guidelines that are just like, hey, bring your home factor. Just that's part of your, list of emergency recommendations, all that stuff.
Yes, exactly. So patients, whether they have severe or moderate or mild hemophilia, would have at least one dose of factor at home that they would take with them and would also take with them, like if they're traveling. We, always encourage our patients if they're traveling to identify whatever hospital they would go to in the area, because as it turns out, you go on vacation and that's when you hit your head and need to go to the emergency room.
Yeah.
So that's something they travel with and bring along with them. And
just, is it a refrigerated product? Just because I've never seen it.
So that is one thing that is kind of evolving as well, is just like different products having different kind of requirements. And these are the types of things that actually end up kind of mattering sometimes to patients that we don't necessarily think about, right? Like the volume, like how much volume you have to infuse, like matters, right. Especially if like it's a subcutaneous injection and whether you can keep it out or in, and like before it's reconstituted and all of these different, and how long can you keep it in the refrigerator versus not. And those things differ a lot between products, but.
Gotcha. cool.
end up being kind of important for patients.
That's helpful to know that there's so many different options for people.
And so say the patient comes in, gets hurt in whatever way, shape, or form. Knee bleed, bit their tongue, can't stop the bleeding, whatever it may be. Are we doing any specific tests as well? We're given the factor, we're sending you to get our scans, but we're giving the factor first. Is there any test to do, or is it kind of cats out of the bag too? Because even if we measure their factor level, it'd already be up from what they got.
Yeah, so it kind of depends. I think if you have a patient who comes in and hit their head, you're not going to wait to give factor. If you have a patient who comes in and has like a very typical joint bleed where the knee is warm and swollen and is affecting their range of motion, and they have hemophilia, it's pretty clear. There is more and more point of care ultrasound being done. So a lot of hemophilia treatment centers have physicians that are trained within to do point of care ultrasound. And so that can be helpful if there's any kind of question about whether it's truly a bleed. And the important thing to remember, right, is that hemophilia patients have hemophilia and they're at risk for hemarthrosis, but they're also at risk for all the other stuff, right? And so if they have a knee injury, they could have an ACL tear, or they can have all of the things that other people can have. And so it's important not to miss those things just because we're so focused on the bleeding. But I would say if clearly they come in and they had a bleed provoked by something, then you're treating the bleed, and depending on it, the mechanism, or if there's anything else going on, then maybe other imaging or stuff is indicated. But if you have someone coming in, for example, and they were doing nothing and they were bleeding, and you have them on really good prophylaxis, then in that case, we might ask that you check for an inhibitor, right? Because it may indicate that their prophylaxis is not working, especially if they come in and have had a spontaneous bleed and they're on something that should be protecting them from that.
Amazing. So I'm curious to hear a little bit about how you talk to parents about how to balance allowing their children to live normal lives as active, excited kids while also keeping them safe. Because I imagine that's something that a lot of parents are struggling with when they get this diagnosis.
Yeah, it's super hard. So I would say it is different with every family, but it's really challenging, right? Because you have a disease where we have really great treatments and patients can have really great outcomes and do super well, right? Like most of our pediatric patients have never had a joint bleed. They participate in a ton of things and are awesome at them and lead, very normal lives. But it is a disease where you have patients who have intracranial hemorrhage and die, right? And so to balance those things, right, of if your child hits their head or if your baby's not waking up, that could be really, really bad with it's okay. Your child's going to be okay. You can not put them in a bubble. And there's definitely a spectrum of parents, right? So there's the parents who are really nervous and they really restrict a lot of what their kids are doing. And a lot of times that can lead to other issues, right? So we have a lot of our patients, not a lot, but there's some patients who haven't been active because they've been really nervous and become overweight or obese. And that's really hard on your joints, right? And so that's then going to put you at risk for joint disease and joint bleeds. And it can be really hard starting something once you are overweight or obese, because then there is also that, risk of joint bleeds. And then on the kind of other side of the spectrum, there are the families who football is a huge part of their family culture and they dreamed of their child playing football. And so the National Bleeding Disorders Foundation that I mentioned before has a really nice document that they have laid out kind of all different activities and kind of red light, green light of these are activities that are great for your child with hemophilia, and these are activities that we wouldn't recommend, which generally include things like football, boxing. I always joke about ultimate fighting is not really encouraged. But on the flip side of that, we say we don't recommend these things, but I would much rather my patients tell me if they're going to do them, so that we can try to prevent whatever we can prevent, and so that they understand when they need to present to care if something does happen. Because there's always going to be patients that, despite you educating and saying, this might not be the best sport for your child, make the decision for their families that that they still want to do that. So then it's our job to support them to do that as safely as they can, in my opinion.
Yeah, I mean, you talked a lot about maybe football not being an ideal sport for these kids, but like, if they hit their head doing, another activity, how are you telling them to come in to the ED each time? What are they looking out for there?
Yeah, so it's really hard, as you can imagine, because there's so many ways to hit your head, and there's like an impossible question, right? Because even if you just thought about for like a kid without hemophilia or without a bleeding disorder, like when should you go in, right? Like we have PCARN, which is great if you don't have a bleeding disorder, but PCARN doesn't really apply if you have a bleeding disorder. So it's really challenging because parents will ask that, like, well, how hard do they need to hit their head? And it's like, I can't tell you the velocity and right. I can't like outline the physics for you of what that looks like. So I usually just try to kind of counsel on, definitely if it was something that you'd bring your child without hemophilia in, then you need to, and kind of like a little bit more than that, right? Like, it's more concerning. They're at higher risk than a child without a bleeding disorder. But it's very difficult to quantify that. And I think I try to err on the side of, call us or come in rather than not, because I'd always prefer they call and it be nothing, or come in and it be nothing than the opposite of that.
Angela, I know a lot of these kids are super independent, right? We talked about how parents at first are doing venipuncture, but then kids are growing into managing their own illness. I was curious how you sort of approach kids participating in their own care and how that affects their development as, school age or middle school age kids.
It's amazing. It's the coolest thing ever to see. So we, at our center and at many centers, we have like a hemophilia camp. That it's not just specific to our center, but it's like kids from all over Michigan go there. And historically, a lot of kids learn to infuse there. So typically with patients who are doing infusions at home, we will encourage parents to kind of involve them in whatever way they're kind of willing or interested, like as they grow up, right? So maybe in the beginning when they're little, it's just getting the factor out and setting out like the things that they would need to infuse. Or then maybe the next step is like, oh, okay, they clean their skin where their parent is going to infuse, or they, help reconstitute the factor. And so typically, it's like a little bit of exposure at a time. But at Hemophilia Camp, they have what's called the Butterfly Award, which is like that you infused yourself. And definitely when kids everyone used to be on infusions. It was a really big deal. And it was this kind of nice thing at camp where like everyone goes and infuses together at the same time. Now, so many people are not infusing or are infusing a lot less frequently. So it's not as much of kind of like a community building thing. But there's still kids. Like I had a 7-year-old at camp this past summer who I've known since he was a baby, and he has helped his mom at home doing things, and he was so excited, and he poked himself for the first time and got it right away, and the look on his face was the best thing I've ever seen in my life, and he was so proud of himself, and I was like crying, and I'm about to cry just thinking about it, because he's 7 and he infused himself with an IV medication, and he's like asking me like, Dr. Angela, do you know how to do this? And I'm like, oh, I can't poke myself. I'm not even willing. Hemophilia. Do you know what I mean? But I told him next summer that he could teach me, because I got to get over my fears. If he can do it, like I should be able to do it. But right, that's incredible. 7-year-old kid, like finding his vein, poking himself, infusing his factor. They're heroes. It's beautiful. It's amazing.
Yeah,
I was not doing that at 7.
No, I can't even fathom.
I'm
It's
way
like
older than 7.
Yeah, it's actually truly unbelievable. But what, what people will do to adapt and to to step up into these ways, it's amazing. It's really amazing.
Yeah.
Well, because hematology right now is a field that is really rapidly changing with a lot of the medicines that we have, and maybe even cures coming down for different disease processes, we were really hoping to talk before we go about any new therapies you see that are really coming down the pike that we should know about, maybe what's going to happen with this disease process in the next 5 to 10 years.
Yeah, so it's been a really exciting time to be in hemophilia. I'd mentioned the emicizumab and the marstacimab that are approved. I didn't mention, but there's actually approved gene therapy for both hemophilia A and B that have been approved in the last few years. Those are only available for adults and are not currently really being used in patients who have a history of inhibitors, but are options for adults with hemophilia, and kind of with varying efficacy. The factor 9 gene therapy, the factor levels stay higher for longer. They seem to be more durable versus the factor 8. We do see some decrease in factor levels, and there are patients who don't even respond initially to the gene therapy due to some immune response and lose expression. So that's an area where there's a lot of work being done and a lot of interest in that. It's definitely not a cure. Like when we think of gene therapy, I think a lot of patients think like, okay, I'm never going to have to infuse again. But at least for patients, it's likely that they won't have to infuse for at least a number of years. So there are patients getting gene therapies and further gene therapies in the works. And then other kind of rebalancing therapies are being developed. So one's targeting antithrombin is I think close to approval, probably we'll see approval next year. And that's a subcutaneous option. It's called fitusiran, and it's likely that most patients on that will be dosed once every 2 months. So pretty infrequently. And then there's new mimetics being developed, so similar to imicizumab, but that they think may be like more potent. And so maybe instead of converting a patient with severe hemophilia to a factor level 15, maybe they're going to be converted to a higher kind of steady state factor level. So there's multiple mimetics in development. And then people are always talking about trying to get like an oral factor 8, which so far has not been accomplished, but there are things that are looking more promising kind of in early development.
And these, it just, we didn't talk so much about the rebalancing therapies, but the rebalancing therapies, to, give you a different clotting factor to essentially clot. Do you think that's going to be where the money's at? Or do you really think it's going to be, hey, if we can infuse a capsid that will then, create factor for you and then you're self-creating factor, that's really where the game's going to be?
I mean, I think it's going to be different based on the patient. And I think that's what's so amazing about where we are now is that we have really great options that some patients, like when you asked before, is there like this is what you start with, right? It's like, if I have a patient, but if you have a patient who's like super active, right, then you probably want some peak levels and maybe like a long acting factor is going to be better versus a patient who really has difficulty with IV access, then a sub-Q thing is going to be better. And with the rebalancing where we're decreasing one of your natural anticoagulants, I think the exciting thing about those medications is they're more like pan-hemostatic, right? They're not replacing factor 8 or replacing factor 9. They're decreasing, antithrombin, which presumably, hypothetically, could be used for any bleeding disorder. It has its own issues, right? Because if you think about patients with antithrombin deficiency, they have DVT and VTE events, right? And so that's concerning, but that's kind of what they've been doing with the antithrombin fitusiran is figuring out that sweet spot of where your antithrombin levels need to be to not have abnormal clotting, but to prevent bleeding from occurring. So I think it's going to be different for every patient, and there are issues, specific to all of them. None of them are perfect, and definitely none of them are perfect for every patient, because even with the gene therapy, currently the approved gene therapies are AAV vectors, and within the general population, not small proportion of people already have antibodies to those vectors, and so just out of the gate aren't necessarily eligible for those. So I think it's amazing that we have as many different options, but it's not going to be the same answer for every individual patient.
Awesome. Well, thank you so much for giving us all this information on hemophilia. Before we go, we always like to ask take-home points. Are there any things, a couple things that you think that all our listeners should know after listening to this episode?
So I think, one, it's never going to be the wrong answer to give factor, right? If there's a hemophilia patient that you're concerned how to bleed, even if especially if it's something like they've hit their head, giving factor first is going to be the correct answer. I think just appreciating that the diagnostic journey is complicated, right? That a normal PTT isn't going to rule this out entirely, and that factor levels are definitely needed, but also have to be interpreted in the context of what's going on in terms of developmentally, but also inflammation or other things that can affect those. And then I think a big thing for me is just appreciating that women do have hemophilia, and we, unfortunately, all of the research and knowledge that we have is from males with hemophilia, and the little that we've studied and know about women shows that it's not the same and that there are differences. And so we can't just use everything we've learned in men and extrapolate it to women, because that's not likely to work very well.
Awesome. And then for a final piece, is there anything you'd like to plug? Any societies that we should check out? Any of those type of things that we should send our listeners to?
Healthcare Workers versus Hunger is starting this week, but it's not going to be, like, it'll be over by the time the episode is out. So I don't even think I have anything to plug.
That's okay. That's okay. We'll plug hemophilia for you. We'll plug hematology for you.
Perfect.
We'll plug pediatric hematology. We'll plug all of them.
Perfect.
Thank you so much for coming on the show. It's been amazing.
Thanks for having me.
As a repeat guest, we would love to keep bringing you back if you're okay with that too.
Yeah. Thanks for having me. It was fun.
Awesome.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Hartley Lidsky and Avram Rago, and our wonderful social media team on Twitter and Instagram.
I'm Hartley Lidsky.
I'm Avram Rago.
And I've been Sam Mazer. Thank you and good night.